of slides as by way of introduction. And so we're here to talk today. This is a COVID knowledge exchange echo session that you're here on. And today, a highlight of our conversation will be the role of HRCT in COVID or other imaging in COVID. We had presented this on Tuesday, but there was overwhelming demand and we ran out of capacity. So because of the demand, we're here today. And it's a wonderful collaboration with a number of people. And we're really pleased that Dr. Priscilla Joshi from Bharati Vidyapeeth Medical College and Dr. Sujata Rege as well from Bharati Vidyapeeth. And we'll be joined by Dr. Aditya Kasarabada from Virginia. So to give you a sense of what this is about, what is the aim of this activity? The aim of this activity is knowledge exchange. And that's what we realized the last time, that, for instance, the amount of experience people have gained in Pune in the front line, unfortunately, because of COVID, is tremendous. And unfortunately, again, in other parts of the world, we've all been forced to learn on the fly about COVID and what to do. So this is an opportunity for us to exchange knowledge. And it's knowledge not at a theoretical or a research basis, but it's knowledge in the front line. And so everybody, this is a conversation of people in the front line. So our goal is this is not a webinar. This is a knowledge exchange echo. And what we're trying to do is we'll have a brief didactic and then case-based discussions. Anyone can bring a case to discuss, and we'll ask you at the end a little bit about how we should go forward. And really the focus here is we all teach and we all learn. So that's really important. I want to introduce also, this is Operation Breathe, and we'd like to all together help Pune and Punekars breathe better. We've had wide collaborations, and the collaborations are not just limited to Bharati Vidyapeeth faculty and alumni of AFMC Pune, but really physicians everywhere on the front line of fighting COVID. And we're really pleased that there are so many physicians from Pune who've joined. I want to briefly have the JPIGO folks. This is an NGO involved in capacity building in COVID. Can I invite a representative of JPIGO to tell us about Dr. Shinde, perhaps?
Guru is also there.
Yeah.
Also, yeah.
Dr. Suranjan, sir, are you there?
Good morning, everybody, and good evening. Thank you for coming to this meeting. Today, as Dr. Krishnamurthy mentioned, this is an exchange of knowledge with a special focus on Pune. We do have a lot of people who are not here from Pune, and we really welcome them. It's a place to share cases, to seek guidance, and to share our experiences in taking care of this pandemic. We, JPIGO, thanks to generous donations, are now working closely with the Pune municipality, both at the Pune Corporation and Pimpri-Chinchwad, to be able to streamline the efforts that these governments are doing to contain and tackle COVID. Thanks, everyone.
Thank you. Thank you, Dr. Suranjan. And I'd also really thank ECHO India. That's really a whole concept and platform. Please, from ECHO, will that be Dr. Balla, or who's going to present? Please introduce.
I think, yes, sir. Myself, Sandeep, sir. I'm Associate Vice President, F2 Batcher, AFMCI. I'm working as an Associate Vice President in ECO India, looking after the ECO India operations. On behalf of ECO India, we are really humbly thankful to all of you, and we are supporting this activity. The purpose is to dissemination of knowledge to our all medical fraternity colleagues from all across country. So thanks to all those who have joined hands, Bharati Vidyapeeth, alumni of AFMC, JPIGO, and all my senior colleagues from AFMC too. So thank you on behalf of ECO India.
Thank you. Thank you. We will go right on to our conversation, and I will stop sharing. So please, is it Dr. Kasarbada who'll start?
Yeah, I'm going to start in just a second. Let me just share my screen. Can people see my screen?
Yeah, if you do it in the presentation, like a screen show mode, it'll be easier. Yeah, if you hit screen show on the PowerPoint on top.
Yeah.
Hit share screen and select your PowerPoint. Yeah. And hit slideshow on top there. Yeah, there you go.
Okay. My name is Aditya Kasarbada. I'm an associate professor in pulmonary and critical care at University of Virginia. I'm also the medical director for the medical ICU at the Innova Fairfax Medical Campus, which is the quaternary care, transplant and ECMO center in the local Washington, D.C., Maryland, Virginia area. This is where we had most of our COVID patients sort of transferred to when the COVID surge really hit this area. So we're going to talk a little bit about HRCT. And so the general concept of the talk is going to be more about CT, HRCT, some differences about what HRCT is versus conventional CT, the indications for it, some guidelines which are out there regarding CT. And Dr. Joshi, who is a radiologist at Bharati Vidyapeeth, is then going to take over and sort of go over some of the images and imaging for complications when it comes to COVID. And Dr. Rege, who is an infectious disease specialist, is then going to follow with cases to sort of drive home the points we've been talking about, and so that we can all understand about how to sort of when to order CAT scans and what is the best way of going about it. So without much, let me get started. So what is an HRCT? So HRCT is slightly different from a conventional CT. It's a technique, it's a high resolution CAT scan in which the CT images are post-processed for higher spatial reconstruction. This allows us to have like to be able to see the lungs in exquisite details. The current generation HRCTs can have, you can have thickness of like 0.6 to 1.5 millimeter cuts. These are not exactly, these are done every couple of centimeters, which allows you to have like really good resolution of the lung parenchyma. There are a couple of ways of actually doing this in HRCT. And so the current standard is volumetric volumetric sections, which allows you to take an even thinner slice of it. But the flip side of that is this does make for a higher dose of radiation for patients. So when we talk about CAT scans in the lung, the primary structure is called a pulmonary lobule. Think of it this as a pentagonal area, which is sort of surrounded by the interlobular septum, which contains both, like, so this would be the interlobular septum, which contains the pulmonary artery, the pulmonary vein, as well as the lymphatics. The pulmonary artery, as well as the bronchiole, are in the center, and then the interstitium is in the middle part about it. As a way to sort of give an example, we all know about the curly B lines that you see on X-rays. Anything that is there in the so the curly B lines would typically be represented by the interlobular septum here on the CAT scan. So this is also kind of helpful to think about it, because when you look at the CAT scan, you can sort of look at if the interlobular septum is thickened, then you sort of think about disease which affect the lymphatics as well as the pulmonary vein. If you think about the center, you think about airways and the pulmonary artery and so on and so forth. So sort of it helps you focus on where the problem is and what your differential could be while looking at the CAT scan. Okay. So some of the common terms that you end up hearing in CAT when it comes to looking at CAT scan reports, and CAT scans are ground glass opacities, interlobular septal thickenings, and intralobular septal thickenings, honeycombing, traction bronchiectasis, fibrosis, and consolidation. And so we'll sort of talk about that a little bit. So when you think about ground glass opacities, which is sort of the fundamental part of CAT scan, is you can see the actual architecture of the pulmonary lobule, but it is not as clear. So the term actually comes from the Sistine Chapel, where Leonardo da Vinci has these beautiful glass paintings. You can see through the glass paintings and you know a general sense of the structure, but you cannot see clearly. And that's your ground glass. When it becomes completely sort of opaque and thick and white, kind of like that, then that is considered consolidation. So when these interlobular septal becomes thickened, you'll see other processes. When it comes down to fibrosis, what ends up happening is when the airways are all tethered to one another, and so when the parenchyma actually fibroses, it tends to pull the airways apart. And so that would be your traction bronchiectasis, and you're able to see the airways in areas where you should not be able to see some. Honeycombing just refers to completely destroyed lung that you normally see. And so I want to show you some examples of some of these findings. So this would be a representative cut for a normal CAT scan where you can see normal architecture. Typically, depending on the resolution of the CAT scanner, you may not be able to see the the pulmonary lobule. Depending on the resolution, you're more likely to see it in the upper lobes, but here you can sort of make out one of these. Hopefully the resolution on the Zoom is good enough for you to see some of it. Moving on, this would be a representation for a ground glass again. So here you can sort of see a lobule, make out a structure, but it's kind of hazy, but not completely whited out. So this would be ground glass. As a comparison, consolidation is right next to it, where you can see it's completely white and there's no architecture to be seen here. So that would be an example of consolidation. The interlobular septal thickenings, again, you can sort of make out this is your pulmonary lobule. Actually, that would be another one in there, but these are all thickened as this. So that would be an example of the interlobular septal thickening. When fibrosis occur and airways start getting pulled apart, you start seeing airways in the periphery. On a normal CAT scan, as in the very first image, as you could see, you can normally not see the airways this far out. And when you start seeing that, there is some traction bronchiectasis happening. Honeycombing, like I said, is destroyed lung, which is all here. And so this is just completely damaged lung where there's no gas exchange happening. And there's no recovery that'll happen in these areas at all. So COVID is a unique disease where you'll see all of these findings. This is a series of CAT scan images from a patient. Again, this is a normal CAT scan to compare patient in the early part of the disease where they have some sort of ground glass that you can see, which progresses further. We start seeing some traction bronchiectasis as you start seeing airways out and some fibrotic changes towards the later part of the disease. You'll start seeing honeycombing across here and more fibrotic changes that come across in these patients. Here's another example of a COVID patient. This is on day 3, 5, and this is 7. And this is, I believe, day 13 that is there. As the disease has progressed, how the lung involvement has gotten worse in this particular patient. And Dr. Joshi has a lot more examples of some of these findings. So indications for a CT chest in COVID, typically in the United States, we do CAT scans looking for secondary infections in COVID as when patients oxygenation and pulmonary function starts declining. The other places we look for is to look for fibrosis and long-standing cases to decide if there's something that is there in the lung that we can recover or not. CAT scans have also been used as an aid to sort of figure out better ventilation strategies in intubated patients. Pulmonary vascular complications is another one, with PE being one of the more common reasons to look for causes for hypoxia in COVID patients. And of course, there are complications of COVID, as in pneumothorax and pneumomediastinums that can also happen when it comes with COVID. And so those are the other reasons to get a CT chest in patients. In India, all of these indications are definitely there. Along with that, what is also CAT scan is also used for is early detection and staging. And so we're going to talk a little bit about that as well. So in April 2020, last year, at that time, COVID was seen in about 15 countries. And so experts from these 15 countries set up a multinational consensus committee, which put out this consensus statement, which was endorsed by several international societies, including CHEST, as well as the Fleischmann Society, which is one of the top societies in radiology, and CHEST, which is one of the top societies in pulmonary medicine, endorsed it. As to the role of chest imaging in patients' management during COVID-19 pandemic. So these consensus committee included pulmonary people with pulmonary background, critical care background, as well as radiology and anesthesia, who sat down and along with infectious disease, who sat down and came up with these set of recommendations at that point, looking at the first 1 million cases that were out there. The basis of the essential points that come out is imaging is not indicated in patients suspected of having COVID-19 with mild features unless they are at risk of disease progression. Imaging is indicated in patients with COVID-19 with worsening respiratory status. And in a resource-constrained environment, imaging is indicated for medical triage of patients suspected of having COVID-19 who can present with moderate to severe clinical features and a high pretest probability of disease. And so we're going to sort of go over some of this in detail in the next few slides. Some of the basic definitions and the other assumptions they made are this. So when they stated somebody had mild disease, what that meant was there was no evidence of significant pulmonary dysfunction. That means there was either an absence of hypoxia or there was mild no dyspnea or mild dyspnea. Anything beyond that was considered anywhere from moderate to severe. And so for the purposes of these guidelines, they were all lumped into one category. Pretest probability would be low, medium, and high based on the disease transmission that is happening in the public at that time. For example, low would be sporadic transmission, medium would be cluster transmission, high would be community transmission. Currently, India would be considered a high pretest probability because of community transmission. Parts of the United States are still considered high community transmission, and certain parts are moving towards medium, where we have some cluster transmission being seen. The other thing to keep in mind is the big ones are risk factors for disease progression. And so the common ones that are there that we all know about are age greater than 65 and presence of other comorbid conditions such as cardiovascular diseases, hypertension, diabetes, chronic respiratory disease, like COPD, asthma, and anything which would make somebody immune compromised. So these would all be would make patients at higher risk for disease progression. Again, going over the same risk factors again. So let's look at some scenarios. So based on these assumptions, the committee looked at 3 basic scenarios of COVID and try to look at where imaging would be appropriate or not. So the first scenario is patient has mild features of COVID. So again, we are talking about somebody who has no hypoxia and no to mild set of dyspnea is there, but has some features of COVID. So you could sort of look at it in 2 ways. One, you get a COVID test, and they could be either positive or negative. Now, if they are negative and they have features of mild COVID, imaging is not indicated at that point. And so the recommendations are to monitor for worsening respiratory status. If that shows up, then imaging is indicated. If it does not show up, then you continue to monitor. And we have to understand that quite a few patients will end up falling in this category because they don't necessarily progress. The next category would be you have features of COVID, but your COVID test is actually positive. So at that point, you look for risk factors for disease progressions, the ones that we talked about: age greater than 65, cardiovascular disease, hypertension, diabetes, chronic respiratory disease, or anything that would lead to immune suppression. So if you have any of those and you have a positive test, then imaging is again indicated to, and then you continue to watch for monitoring for worsening respiratory status. If those risk factors are not there, again, you sort of wait and watch and look for worsening respiratory status, as imaging is not indicated at that point. It is sort of held off till any sort of respiratory symptoms come into play. So this is sort of the flow for patients with mild symptoms of COVID. Now, you could come, the next scenario would be moderate to severe, and you have any pretest probability. It could be high, low, medium, high, low, or medium, and there's no resource constraints. So if you are in this situation, you can get a COVID test, and if it's positive, then imaging would be indicated, because again, we're talking about patients with hypoxia. Just so we're also clear here, the mention is imaging, not like a CT as such. Any sort of imaging is indicated here at that point while you're monitoring for worsening respiratory status. And if the respiratory status worsens further, then you could sort of select a different modality of imaging if needed. If the COVID test is negative, then what it says here, imaging is needed. And the thought process behind that is, let's just forget the scenario in which COVID was not there. So when COVID is not there also, if somebody walks into your office and he's severely dyspneic or is hypoxic, you would still get imaging at that point, be it chest X-ray, be it CAT scan. And so normal pre-existing guidelines for normal pre-existing diseases need to be taken care of too. And so that is the thought behind why, even though the COVID test is negative, and imaging is still recommended in this category. And so the idea here is you're looking for other disease processes as well. The last scenario is the third one, where you have moderate to severe features of COVID, but you also have high pretest probability of COVID. And now you're also in a resource constrained environment where your need for urgent triage because of ventilators, resource like PPEs, beds, anything that is there. So the guideline, the suggestion is, well, is a COVID test available? No, if it's not available, they have moderate to severe features. Again, you still have to look for other causes as well. And so do the imaging and see if you can find any other reason for it, or if the imaging suggests that the patient likely has COVID, to sort of help triage what is happening here. If not, if you do have a rapid COVID test, get the rapid COVID test. And again, it sort of splits off into positive versus negative, trying to decide how you whether you should actually be doing imaging or not. And so again, sort of these were considered a balance between what is available, understanding the fact that COVID causes respiratory problems, along with the fact that there are other pulmonary conditions also which cause respiratory problems, and to balance both of them so that we do not miss any other disease process as well. These guidelines came out in first week of April in 2020. Now, in the United States, what ended up happening was around the same time, and in fact, if memory serves correctly, 2 weeks after these guidelines came out, rapid PCR became widely available, where our turnaround for test was an hour in the quaternary care and the tertiary care centers, and in others, in other hospitals, it became close to like anywhere from 6 to 24-hour turnaround times. So with that rapid turnaround time, some of these United States, most parts of United States moved away from imaging because rapid COVID test was freely available at that point. We moved away from using imaging as a tool to aid in early identification of COVID. With that, I'm going to stop here. We're gonna try and sort of take some of the questions towards the end, after Dr. Joshi and Dr. Rege also make their presentations and sort of make some of these points that I made a little more clear. Thank you.
Thank you. Requesting Dr. Joshi to please share her slides. Dr. Joshi, you're muted, perhaps.
In the next 15 minutes or so, I'm going to take you through the imaging findings we see in COVID. And I'm Dr. Priscilla Joshi. I'm a radiologist at Bharati Vidyapit Medical College, Pune. So the role of imaging over the last year and a half has evolved during the pandemic, initially with CT as an alternative and possibly superior test compared to RT-PCR, to a more limited role based on specific indications. So the imaging modalities we have available with us are plain radiographs, CT scan, and ultrasound and color Doppler, of course, MR in certain circumstances, but I would basically be dealing with plain radiographs and CT scan. There's been a lot of news regarding the amount of radiation each person is exposed to during the CT scan, and it has been said that each CT scan exposes a patient to radiation equivalent to 300 chest X-rays. And there have been clarifications from the Indian Radiological and Imaging Association as well as the Chest Society of India. And what actually is the amount of radiation a patient is exposed to is around 70 times a chest radiograph, which itself is a lot. So therefore, it must be judiciously used. This is a CT dose which I've got from our machine, which is around 7 millisieverts, and a plain X-ray is about 0.1 millisieverts. The newer machines, of course, give you lesser radiation. It should be remembered that the chest imaging findings of SARS-CoV-2 mimic other coronavirus infections like the SARS and the MERS, H1N1, influenza virotypes. They also mimic acute lung injuries, drug reactions, and connective tissue disorders. Therefore, RT-PCR is the gold standard. Chest imaging is only indicated for patients with more severe disease or risk for worsening respiratory status. Also for evaluating vascular and cardiac complications of COVID-19. What is the pattern of lung involvement? Aditya has just told you and shown you various patterns of involvement. Imaging may be absolutely normal in mild cases and if done early during the illness. The organizing pneumonia pattern of injury is the most common, and in some patients, one can get a diffuse alveolar damage. It should be remembered that the extent of the chest X-ray and CT findings correlates with the clinical indicators and the severity of the clinical course, but imaging alone is insufficient to determine the outcome. There is a high inter-observer agreement across all levels of experience as far as the classification system of CT findings related to COVID-19 is concerned. On chest X-ray, like I told you, initially in the disease, you may just get a normal chest radiograph, and in milder cases, that may be the case all along. Unilateral or bilateral lung opacities with more of a basilar and strikingly peripheral distribution are the other finding. This, of course, is a more severe case. The baseline chest X-ray has a relatively low sensitivity, only 69% for COVID-19. Comorbidities like chronic lung disease or congestive heart failure may confound interpretation. It should also be remembered that many of the hallmark chest CT findings are apparent on the chest X-ray, as in this case, this was an emergency medicine consultant who had COVID last year. And she suddenly called me up one day and said, I'm feeling a little breathless. And when we saw her chest X-ray, there was this opacity, which we saw here in the basal region. And we were new to COVID those days. We did a CT for her, and these opacities were seen on the chest CT as well. And steroids were added to her treatment, and she recovered uneventfully. Our patient zero was a 42-year-old Anganwadi worker who came to us on the 16th of March. This was her radiograph on the 17th of March, which showed the classical opacities peripherally, more in the lung bases. She worsened, and this was her subsequent chest radiograph on the 22nd, still worsened, but finally she did better and went home on the 8th of April. She was monitored all throughout with chest radiographs. No chest CTs were done for her. There is a scoring system available on chest radiographs as well, and this has been shown mentioned by certain authors. On the chest radiograph, the lungs are divided into 6 zones, 3 on each side. The upper zone extending from the apex to the aortic arch profile Then from the aortic arch profile to the inferior margin of the left pulmonary artery, that's the middle zone. And from the inferior margin of left pulmonary artery to the diaphragm is the lower zone. Depending on the extent of lesions in each zone, it can be categorized as either 0 with a normal lung parenchyma, only interstitial involvement as 1, radio opacity less than 50% of lung parenchyma is 2, and more than 50% of lung parenchyma as 3. The CORADS, that is the COVID-19 reporting and data system, is also available. CORAD 0 is not reportable due to technical factors like patient movement. CORADS 1 is there is no evidence suggesting COVID, it's a negative scan. CORADS 2 has a low suspicion for COVID-19. CORADS 3 is indeterminate or unclear. CORADS 4 is suspicious for COVID-19, and CORADS 5 is a very high suspicion or typical for COVID-19. CORADS 6 are patients who are PCR positive. The percentage of lobar involvement is what gives you the CT score. The right lung has 3 lobes, the left lung 2 lobes, so a total of 5 lobes. Each is given a score from 0 to 5. The total score is out of 25. If there is no involvement, it's a score of 0, less than 5%, 1, 5 to 25%, 2, 25 to 50%, 3, 50 to 75, 4, and more than 75%, 5. A score of 7 or less indicates mild disease, 8 to 17 is moderate disease, and 18 or more is severe disease. So let's look at this example of scoring. This was a patient who had fever and cough since 3 days. There was no dyspnea, no comorbidities. This was the scanogram, which showed extensive opacities over both lungs, more peripherally located, which is classical for COVID-19 pneumonia or any viral pneumonia. In the upper lobes on the right side, a score of 3 was given due to 25 to 50% involvement. Left side 2, right middle lobe, there was a score of 3 given, 25 to 50% involvement, and lower lobes on the right, a score of 4, and on the left, which was more extensive involvement, was 5. So that was a total of 17 on 25, which still fits into moderate COVID, but is on the borderline for moderate and severe COVID. This was a 44-year-old patient, RT-PCR positive, day 4, not vaccinated, no comorbidities. There are few opacities seen, showing a sort of ground glass pattern, peripherally distributed, a little more in the lower lobes. This patient had a CT score of 5. Do you think this patient needed to get a CT scan done? I would leave you to mull over it. 34-year-old patient, RT-PCR positive, with fever, not vaccinated, no comorbidities, day 5. Again, opacities are there, fewer in the upper lobes, more in the lower lobes, more denser in the lower lobes. And in the lower lobes, you're seeing bronchi within this fairly dense consolidation. This patient had a CT score of 12. 58-year-old, RT-PCR positive, day 15, no comorbidities, not vaccinated. This patient had a CT score of 20. You can see there is more extensive involvement. There is denser consolidation. There is interlobular septal thickening. And this patient, yes, definitely deserved a CT for further management since the condition was not good. But this was day 15. So probably we are looking at somebody who is not doing well and oxygen requirement remains, so whether he is going into a long COVID. So the lung lesions which we saw last year were mainly like this, a ground glass haziness, like Aditya told you, through which you could see the vessels and the bronchi. Denser consolidations like this, where everything is obliterated. We are seeing more of these lesions because we are scanning early in disease, which we should not be doing. So multiple nodular opacities we are beginning to see because we are scanning early. We are also seeing the reverse halo or the atoll sign with a central density and a halo followed by a surrounding consolidation. This is what Aditya showed you, the opacification, ground glass opacification with some amount of bronchial dilatation and vascular dilatation through it. What I've shown you so far has been typical for COVID or any viral pneumonia. But what is unusual in COVID-19 is lobar consolidation, unilateral involvement, lymphadenopathy, and pleural effusion. Cavitation is also something which is unusual in COVID. This was a 23-year-old boy. He was a known case of ALL who had fever and cough since 3 days. And what you're seeing here is a nodular lesion within a cavity with a surrounding halo, which seemed more like a fungal infection. And this patient was indeed treated with antifungals. What we are seeing more of this time around is more formation of these cysts or pneumatoceles or bulla, whatever you would like to call them, because of lung destruction. We are also seeing more of pneumomediastinum as in this case. This was a 65-year-old male patient with cough since 8 days, COVID suspect, diabetic. And what we are seeing here is a large, thick-walled cavity over here with some contents. Same thing you're seeing here. This patient was gene expert positive for tuberculosis. However, he also had this area of ground glass opacity in the left lung, so he could be having tuberculosis with associated COVID infection. The HRCT changes show a temporal evolution. In the early stages from 0 to 4 days, there is a ground glass opacity with the crazy pavement pattern, predominant lower lobe involvement. It progresses between day 5 and day 8 with extension of the GGOs and increased crazy paving pattern. In the peak stage between 10 to 13 days, there is consolidation. After 14 days, absorption starts and there is gradual resolution. Complications have been seen more often of late in COVID, and these include cardiovascular complications, thromboembolic disease, myocarditis, MISC, abdominal complications, and neurological complications. This was a 46-year-old patient who was COVID positive with cough and fever for 8 days. He was hypertensive, diabetic since 2 years, not vaccinated, with feeble pulses in the lower limbs. By COVID positive, I mean RT-PCR positive. On CT angio, he had extensive thrombosis in the left common iliac artery and the femoral artery. There was non-visualization of the common iliac and the femoral arteries right from distal to the aortic bifurcation up to the mid-thigh. He also had multiple splenic infarcts. He had bilateral renal infarcts. There was a thrombus in the aorta, and he also had a thrombus in the left subclavian artery. Of course, the lung showed findings consistent with COVID-19 pneumonia. A 68-year-old positive RT-PCR patient, findings on the HRCT consistent. This was from the apex, which we saw when we were doing the CT angio, findings consistent with COVID. His CT brain showed he had right-sided weakness. His CT brain showed this hypodense area in the frontoparietal region on the left, as well as in the perisylvian region. His CT angiography showed complete occlusion of the left common carotid artery from just distal to the bifurcation to the supraclinoid segment. Fortunately for him, his right internal carotid artery, because of a good supply through the anterior communicating artery, supplied the contralateral side, which you can see opacified here. And he didn't develop a large stroke at this point in time, but unfortunately, this patient didn't make it. Pulmonary thrombosis is something we are seeing a lot of, and this is one such case. You can see the filling defect due to the thrombus within the right lower lobe pulmonary artery. This patient also had extensive consolidation still seen on the left with a pleural effusion. We evaluated the vascular complications which we had over a period of 10 months. The total number of COVID patients treated were 2958. Vascular complications were suspected in 148 of these patients. Out of these, they were confirmed on imaging in 55 patients. Of these, the neurological complications were 43. 43 patients had stroke with vascular occlusion. 5 patients had pulmonary thromboembolism. 6 patients had peripheral vascular occlusion. and one patient had a renal infarct. This was a 27-year-old ENT resident who had traveled home. This was during the first wave. He came back with mild breathlessness, and his chest radiograph was suggestive of suspicious opacities in the lower zones. We were not very sure. His first COVID RT-PCR was negative. The second RT-PCR was also negative, and that's when a CT was done, which showed these classical findings consistent with viral pneumonia, that is COVID-19. Let's look at the post or long COVID-19 imaging findings. This was the husband of a hospital employee. This was his first CT scan. He was a known case of tuberculosis. And on 16th of March, he had the CT, which showed evidence of previous tuberculosis, but his lungs were essentially normal. 20 days down the line, he required oxygen, and the requirement for oxygen continued. And we did the CT scan, which showed extensive opacities over both lungs with interlobular septal thickening and ground glass opacity. He also had a pneumomediastinum, which is seen here as well as here. The patient continued to be dependent on oxygen, and this was a CT done on the 27th of April. He had a CT pulmonary angiography done as well. And the CT pulmonary angiography was normal, but he had developed these cysts or pneumatoceles or bulla. I think we'll have to coin a new terminology for these, as well as extensive interlobular septal thickening, suggesting interstitial lung disease. This was a 41-year-old cath lab technician. This was during the first wave, and he was serially followed up with chest radiographs. This was his initial radiograph, which was not so bad, with some opacities in the left lower zone, worsened further. And he then developed fever. His CRPs were high. He had a CRP of 121 over here and was running fever. So they suspected a superadded infection, and we ran a CT for him. And that showed, in addition to the consolidations, these small cavities with suspicious nodular areas and a crescent sign suggesting fungal infection. And this was proven, and he received antifungal treatment. This was a patient we had recently, 19-year-old male. He was 130 kgs. His weight was 130 kgs, so he could not go into the MR machine. He had already undergone a left eye evisceration for mucormycosis, and he came for a follow-up because of a swelling on his cheek. And as you can see, this is the eye which is no longer there. The globe is missing, and you're seeing extensive soft tissue in the ethmoidal sinus, which is showing some density within, suggesting a possibility of fungal sinusitis. He had these hypodense areas, means darker areas with surrounding enhancement, suggesting abscesses in the infratemporal fossa, over the cheek as well, in the parotid region. He also had a suspicious abscesses in the temporal lobe. And if you see, the cavernous sinus on this side is not enhancing, indicating a cavernous sinus thrombosis. That is clearly seen here as well. It's bulging outwards, and there's a filling defect in it as compared to the opposite side, suggesting a cavernous sinus thrombosis. His cerebral angio, however, was essentially normal. This patient now is likely to be undergoing a maxillectomy for involvement of the maxilla as well. There are multiple conditions mimicking COVID, and such patients had come to the fever OPD with fever, chest pain, and cough. This was one patient who had multiple nodular opacities over both lungs, definitely didn't look like COVID, could be tuberculosis, could be disseminated malignancy. Another patient with pleural effusion, like I told you, pleural effusion, don't think of COVID. Consolidation with breakdown, again, don't think COVID. So what has been different in the second wave? The virus is more infective and virulent. It's a super spreader. The socioeconomic strata involved is higher. That's why we're probably doing more CT scans, because they can afford it. Entire families are affected. Lung involvement is more commonly seen and severe. There are more vascular complications. Post-COVID sequelae, long COVID is more. Residual lung changes in the form of residual lung changes and mucormycosis. In April 2020, Fleischner Society had come up with guidelines saying there is no indication for routine imaging as a screening test for COVID-19 in asymptomatic individuals, no indication for daily chest X-rays in stable intubated patients, and CT is indicated in patients with functional impairment, hypoxemia, or both after recovery from infection, not indicated in patients otherwise. So what are the non-indications? CT is definitely not indicated for routine evaluation of the lungs in asymptomatic, minimally symptomatic patients, and cough is definitely not an indication. Routine pre-admission or pre-surgical evaluation when RT-PCR is available, CT is a total no. Patients' relatives wanting or demanding a CT scan to check the status of lung, management, or in follow-up, again, a total no. And it should not be done as routine evaluation for either management or follow-up of patients. So what are the indications? Moderate to severe symptomatic patients with breathlessness, falling oxygen saturations, COVID-19 suspects for quick triage, in symptomatic patients for isolation or triage, where RT-PCR testing is not available or is available but results are delayed. High clinical suspicion of COVID-19 but negative RT-PCR report, where findings of CT scan will make a difference to the management, like the example I showed you, and certain unique or individual situations where patient has to undergo emergency surgery, RT-PCR or rapid testing is not available or results are not available on time. The routine use of CT scan as a pre-admission or pre-surgical test in non-emergency situations is strongly discouraged. I think this is something which Sujata will be dealing with in the subsequent slides. These are guidelines from the Society of Chest Imaging and Intervention in India. So another thing which I want to bring to your notice here is that the patients who underwent CT scan this time, 90 to 95% of these patients who came had not taken the vaccine. 5% approximately had taken 1 dose, and less than 1% had taken 2 doses. So it's important that you impress upon people that taking the vaccine is what is going to break the chain for us. Image gently, image judiciously when you must. Thank you.
Thank you, Dr. Joshi. That's wonderful. We'll move on to our next presentation with Dr. Sujata Rege from Bharati Vidyapeeth. Dr. Rege.
Hi, good morning, everyone, and good evening to everyone in the US. So I'm Dr. Sujata Rege. I'm a consultant in infectious diseases at Bharati Vidyapeeth. So after excellent lectures by Dr. Aditya and Dr. Priscilla, I'm going to talk about the practical aspects of when you would want to do CT or when you would want to. So our conversation today is mainly about the usage of CT scan in COVID. So it's a disclaimer that most of the scenarios that I'll be presenting and asking about CT, please feel free to interpret it in a way that I would actually want to do maybe an X-ray for some of those patients. But since CT scan is the hot topic for today, the poll questions will be addressed towards CT scan. So I'll go straight away to the cases. Okay, so I hope everyone has their polling. 1 second. Okay. So my case, the case 1 is Mr. A, a 66-year-old male. There's something wrong with my screen. 1 second, please.
Dr. Rege, just to inform you, we had some technical issues with the poll, so we can take their opinion on the chats.
Oh, okay.
If you don't mind.
Okay, sure.
Thank you.
No, there's something wrong with my screen anyway.
No, it's visible.
Okay, all right. Okay, so case 1, Mr. A, a 66-year-old male, has presented to us with fever, dry cough, and malaise for 8 days. He started to feel breathless on day 9 from the onset. So he did his RT-PCR at the time, which tested negative. And he presents to the hospital with saturation of 92% on room air, which means he is hypoxic. So would you do a CT scan in this situation or would you not? So if people can just put their opinions in the chat.
Yes. I think they can raise their hands.
Yeah, maybe raise your hands, those who would do a CT scan here, and maybe we'll assume that the rest don't want to.
Okay. We are getting a lot of responses
Okay,
as yes. Yes.
Okay, so a lot of raising hands.
Yes.
Okay, so all right. So this scenario falls under scenario 1, wherein you have a COVID-19 test which has been done but has tested negative. So initially he was okay, he had fever and dry cough and he was not breathless, so he continued his self-monitoring for worsening respiratory status. And when he had worsening of respiratory status, in this situation, imaging is indicated. So this is a classical example of when you have an RT-PCR which is negative, but you have a strong clinical suspicion of COVID, especially in the pandemic right now when you have fever, dry cough, and hypoxia. COVID-19 is the first thing that you would suspect. So in this scenario, since he is hypoxic, imaging is indicated. And this is what his CT scan looked like. It's showing all the features of ground glassing and everything that Dr. Priscilla and Dr. Aditya have explained in their lectures as well. So this is a situation where some imaging would have been indicated, either X-ray or a CT scan. So we move to the next case. Miss A, who is a 32-year-old female, she is absolutely healthy. She has no comorbidities. She comes with the complaints of high-grade fever, anosmia, and dry cough since for 2 days. She has tested herself on day 2 of illness and has tested RT-PCR positive. Her saturation at room air and after a 6-minute walk is 97%. So, and she comes to you for a consult that, can I do a CT scan or should I not? So what would be your opinion in this? Do we do a CT or do we not do a CT? All
Not needed.
So anybody who says we should do a CT should raise your hand.
Yeah,
right?
so maybe people who want to do a CT scan in this situation, please raise your hand. Oh, yay, my job is done. Okay, all right.
Okay, we have one response, sir.
Okay.
Dr. Sham who has raised his hand.
Okay, all right. So the majority have decided not to do a CT scan for this patient. So let's see objectively where it fits in within our Fleshner scenarios. So this is a patient who with a COVID-19 test which is tested positive, but has no basically any respiratory worsening. So in this situation, imaging is not indicated and you need to self-monitor only, and this patient has to be counseled. A lot of patients are very anxious and they want to do something to know whether they are going to be okay or not. So they need to be counseled more than anything else that no, you need to keep monitoring your saturation. What are the warning signs and when she needs to come back for follow-up. Okay. So this is a scenario where so these are real life cases. So these patients, some of them have come to us directly with a CT scan. So she came in with this CT scan, which is absolutely normal, which again proves the point that there was no indication to do this in the first place. Okay, so we move to our next case. So case 3, this is Mr. Y, a 60-year-old male, moderate COVID, was hypoxic at admission. He had presented to us on day 6. He required oxygen by mask and received remdesivir, steroids, and anticoagulation as per our protocol. On day 13, that is a week into his admission, he developed increasing oxygen requirements, fever, a negative procalcitonin, and increasing inflammatory markers. So his clinical suspicion was primarily of cytokine storm, but we wanted to rule out even a secondary infection or a thrombotic event. In this situation, do you do a CT or no CT? So all those in favor of CT, please raise your hands.
Everybody gets to
I think
vote.
we have I think we have a overwhelming, okay. So let's see what the scenario says. Yeah. So this is a patient who has presented with moderate to severe features consistent with COVID-19. He has tested COVID-19 positive. At this situation, because there is moderate to severe features, he had some imaging which was indicated at the outset itself. After monitoring him for worsening of respiratory status, which was present, imaging is re-indicated. So that is what was done here. So on the left, you can see that this was a CT scan at the time of admission. And you can see on the right that he has an increase in bilateral ground glassing opacities. The CTPA did not show any pulmonary embolism, and he was diagnosed with cytokine storm and treated accordingly.
So
Okay.
I think that there was a clarification, if I may call out. So somebody recommended a CTPA. So that's what you did, it looks like.
Yes. So that's what. So when we were suspecting whether we wanted to diagnose a thrombotic event, he underwent a CT with a CTPA as well. Okay, so I move to the next case. So this is Mr. A.
Somebody asked for a portable chest X-ray. What did you think about that?
Yeah, so that's what I mentioned, that in a situation like this, we are discussing about CT in COVID today, which does not take away from the fact that I would probably do an X-ray for most of these patients. However, this patient, since I wanted to get a CTPA done as well. So if I have an availability of, if the D-dimer has increased, and if I'm finding a suspicious RA-RV dilatation on a bedside echo, I would probably prefer a CTPA with the CT in this case. But in another patient where the D-dimer is not increasing, or there's the pretest probability of a vascular event is lower in that patient, then maybe only a bedside X-ray would be okay. All right, so this is the next case, Mr. A, who's a 55-year-old male. He was admitted to us on day 7 of his illness as a moderate COVID. He was hypoxic at admission. He recovered after 5 days of steroids and anticoagulants. He's off oxygen now for 3 days, no unmasking hypoxia even after a 6-minute walk test, and he's planned for discharge. At the time of discharge, do you do a CT or no CT? So all those in favor of CT, please raise your hands. Oh, wow, okay. No takers? All right. Super. All right. So this patient falls under moderate to severe features consistent with COVID-19 and a positive test. He had an initial imaging done. When we monitored him later for worsening respiratory status, they are absent. He's doing well. There is no unmasking hypoxia. So only continue monitoring and no reason for a repeat imaging of any sort. What we should understand, so this patient, however, did undergo a CT scan, unfortunately, which showed no changes from the earlier CT. So basically, we need to understand that lung imaging changes are not going to disappear or not going to improve within 6 weeks from the initial CT or X-ray. So finding the same changes does not mean that this patient is not improving. So we have to look at the clinical parameters first. So this patient has done well on treatment, is now completely stable. His saturation is maintained even after a 6-minute walk, which itself is a criteria for discharge, and it has nothing to do with the lung imaging. Probably we could repeat his X-ray based on his clinical status later. Okay, so case 5. This is one of the cases, this is a case scenario which falls under our gray zone, which I expect a lot of questions on. So this is Miss Z, a 60-year-old female, known diabetic who is not well controlled. She complains of fever, dry cough, and malaise. She has tested RT-PCR positive on day 4 from symptoms. Her saturation is around 94 to 95%. So it's borderline, although it doesn't fall under hypoxia per se. But her CRP is 50. She has lymphopenia of around 7%, and her D-dimer is 1,500. So do you do a CT here or no CT? So I think Dr. Mohanty asked a similar question of a case like this. So I think we're, okay, the poll is coming in. All right. So a lot of takers for CT scan here, and many not as well. Okay. Okay, so let's discuss. Sorry?
Go ahead. Go ahead, please.
Okay, so let's discuss why the question is relevant. So this is a patient who has presented with mild features. Since the patient is not yet hypoxic, we have to consider it as a mild feature. So this is a COVID-19 test which is tested positive. You need to assess the patient's pre-test probability for having any risk factors for disease progression. So this is an elderly female with an uncontrolled diabetes. She has raised inflammatory markers of CRP around 50. Her D-dimer is raised. She has lymphopenia. All these are risk factors for progression, for disease progression. So in this situation, some form of imaging would be indicated along with monitoring for worsening respiratory status. So this is classically a patient who does not fit in for home isolation and requires admission. I'm not saying the patient requires steroids or anything, absolutely not, because the patient is not hypoxic at this moment. But this patient definitely is not a candidate for home isolation, which is what we need to understand as physicians. Okay, so since we are talking about CT, so this patient did undergo a CT scan, which showed mild to moderate disease. So it's showing bilateral ground glassing. So this patient was admitted for monitoring, went on to develop hypoxia in a couple of days, but is doing well later. Okay. So this is my last case. This is Mr. F, a 40-year-old male who is HIV positive on treatment. He's complaining of dyspnea since a month, gradually increasing in nature, and he also has malaise, anorexia, and dry cough. His RT-PCR has tested negative, but he comes to the flu OPD with a saturation of 90% on room air. So would you like to do a CT? Please raise your hand. Okay. Okay, great. All right. So this patient, since he is hypoxic, falls under scenario 2 of the Fleshner guidelines, where you have moderate to severe features which are consistent with COVID. In today's, because we are in the middle of a pandemic, would I be thinking of COVID-19 otherwise? Maybe not. But anyway, so COVID-19 test has been done, which was negative. So why would you do an imaging in this situation? Maybe to think of an alternative diagnosis, because he's an HIV positive person who has got his symptoms of dyspnea since a month now. And he's also having some anorexia, some weight loss, no specific fever, and he also has a dry cough. So yes, a CT scan was done for him. And this is showing classical features of PCP, where you have perihilar ground glassing opacities and no subpleural ground glassing opacities, which you would find classically in a COVID-19 case. Unfortunately, because of the pandemic, he was still treated for COVID-19, so he received a lot of steroids and no Bactrim, so he eventually did not do very well. Okay, so I'd like to summarize. When would be the optimal time for doing a CT? So by CT, I mean some sort of imaging, and that too, not for everyone, only for patients who you think have a high risk of progression to worsening disease, would be after day 5 from onset of symptoms, if at all you want to do any sort of imaging. What would be the practical indications? If 1 or 2 swabs have tested negative, so you have an RT-PCR which is tested negative, but you have a high clinical suspicion of COVID-19 in a dyspneic patient. If a patient is not dyspneic and you're still suspecting COVID-19, patient has got a good saturation, no unmasking hypoxia. Again, we need to stress, we need to counsel well, and we need to tell them that they need to remain isolated for 14 days and continue monitoring. Okay, if a COVID positive patient has clinical deterioration, then yes, we would want to do some form of imaging in those patients. If there is persistent or worsening hypoxia in spite of steroids, to look for whether inflammation versus secondary infections, to diagnose pulmonary thromboembolism, and also for an alternative diagnosis, because all ground glass opacities are not COVID. In elderly patients who are sometimes immunocompromised, uncontrolled comorbidities with borderline saturation and elevated inflammatory markers, to decide regarding admission for closer monitoring. Currently, thankfully, Pune is seeing a down trending in our cases, but around a month back, we were struggling for beds, we were triaging patients to get admitted or go for home isolation. So those are the situations where something like this, especially in the patients who are falling into gray zone, maybe some form of imaging will help in triaging whether they need to be admitted versus not. But it is definitely, and I cannot stress hard enough that this is not for screening general population. So I hope this was.
Thank you. That was wonderful. Would really like to move on to questions. I know that Dr. Nochiketa Mohanty has been waiting for a while. Dr. Mohanty, do you want to unmute yourself and ask a question?
Yes, so Dr. Mohanty had asked me regarding this case. I mean, I think she had the same question. She was a diabetic who was on oral hypoglycemics, but still having sugars of more than 200. And she has fever, but no respiratory complaints, if I'm not mistaken. And she wanted to know when we can do a CT or some form of imaging. So would it be in the early phase, or would it be in around day 10? Am I right, ma'am?
Thank you. Yeah, she says she's, and then Dr. Chandra Modar had a question. Dr. Modar? Could you unmute yourself?
Hello, good morning to you.
Morning.
Wonderful effort by all of you. I have a question. This is a 74-year female, mildly diabetic, and consistently her pulse oxats are 85 to 89%, sometimes 91 and 90, but otherwise of this range. But otherwise, she's asymptomatic, no respiratory distress. So do we go in for testing or do we go in for a CT to rule out other causes is my question.
So is this patient COVID positive or
No,
is this a diabetic who has saturations of 84 to 85%?
Yeah, because of rampant use of pulse ox, at everybody's place. So, they generally find their pulse oxats low. So do we go in for testing?
No, so the what we need to also understand is the patient obese? Is there any situation where you would think of obesity hyperventilation in this case, who might already have some form of OSA, and you would have
possibly.
Right.
But then is it indication enough to go in for an RT-PCR or a CT scan to rule out other causes then?
So yes, so now this patient actually warrants a more thorough investigations. RT-PCR would be one of the tests, but along with that, I would also want to get some cardiac sort of evaluation done for this patient, because this is a diabetic patient and they very often have silent MIs and might be in failure. We don't even know it. So
Right.
CT scan would not, be able to
Would not be really.
ensure
Yes.
that. But so as a screening, maybe an X-ray to start with, at least if,
Okay.
because in a patient who has 85% saturation, I mean, I would have expected an X-ray to be equally sensitive. To catch any sort of opacities as compared to a CT scan at this point. But along
Right.
with that, more importantly, would also be cardiac imaging in this case, since there are no other clinical features which are suggestive of COVID. Or if there's any family history of anyone being tested positive, then again, that goes in favor of COVID. But if not, and she's just as it is, and maybe change the pulse oximeter.
Right. Okay. Yeah.
Thank you.
Okay.
Dr.
Thank
Vikram
you.
Thank you.
Thank
Dr.
you so
Vikram
much.
Gaikwad and Dr. Joshi have been talking on the sidelines about long COVID. Dr. Gaikwad? Would you unmute yourself, Dr. Vikram Gaikwad? I see that Dr. Khalid Moidu has a question. Dr. Moidu?
My question was, do you think we will have a mass screening solution that is more definitive than the RT-PCR? I mean, if I look at tuberculosis, we shifted from sputum to other forms of tests.
Mm-hmm.
Do you think we will have other forms of tests for RT-PCR?
So honestly, for a screening test, I think by definition, it needs to be highly sensitive and hopefully as specific as well, but may not be as specific. In COVID even actually in TB for that matter, the only test that we have for screening, especially in asymptomatic patients, I don't think a Mantoux test or an IGRA would actually be able to tell you whether a patient has active disease at that point. So the same thing goes for COVID. We need to see what the pre-test probability of a patient having COVID-19 is as compared to mass screening in the form of any test. And it begins as an upper respiratory tract infection and then progresses to lower respiratory. So we need to understand that there are different sensitivities of the test based on when you do the test as well. So whether it is a rapid antigen, which has a sensitivity of around 50%, or an RT-PCR, which also has a sensitivity up to 70%, and that too if we tested within the first 7 days, and it reduces later. So I think, and a CT scan or an X-ray, which we do very early, is going to be absolutely negative. So mass screening, I think we should still focus on testing in patients who have a probability or have clinical features which are suggestive of COVID as compared to just doing mass screening. I think we need to do mass vaccination.
What about Feluda? What do you think about Feluda? I think Dr. Parush Totlani wants to know.
Sorry, I'm sorry.
The Feluda test for mass screening, I think, is that a paper test?
Yeah, I'm not.
Actually, the
Yeah.
Tata
It's not
group,
something
I
that
think
we've used.
yeah, the Tata group had come in with it, and I don't know what happened to it. There was a lot.
Yeah,
of
we didn't see
about it.
any further. I mean, any data published on it. So later.
Dr. Totlani, do you have any experience with that? Parush?
Can I answer the question about the sensitivity also? Dr. Rege gave some excellent points about the sensitivity of the test. I also want to point out something else, like the test that is out there currently does have a higher sensitivity, but the problem that ends up being with the test is how the test is administered, and that reduces the sensitivity down quite a bit. The ideal way of doing it in the nasal swab is actually pretty painful and irritating, and most people end up not doing it appropriately. So that ends up reducing your sensitivity quite a bit. To Dr. Moidu's question, there is another test out there, the saliva test, which has equal sensitivities and specificity when it comes to the saliva RT-PCR test, when it comes to when you compare it to the nasal test, except it's not widely available right now. It is available and it has been approved and available in parts of the United States, and they're starting to ramp it up to as a form of testing, which can be done for kids, because the nasal swabs that we do now are not necessarily the best way to test kids as well. So that if it gains traction, the turnaround time is much faster. The ease of doing the test is much faster. So that is an actual option where that could be used for bigger, doing a lot more screening if it was needed. But currently, those are the big tests that are out there, and it would reduce some of the procedural problems that we now see with the nasal swab RT-PCR. Because again, a lot of the sensitivity and specificity drops off because of poorly conducted tests, not the actual test per se.
Thank you. Dr. Chitralekha Kati has a comment on perfenadine. Dr. Kati, Chitralekha Sharmaji. Please unmute yourself. Hi.
Hi,
Hi, Chitu.
can you see me?
Yes,
Yes.
we can.
Yes.
Yeah, in the second wave, which started around March, I didn't know what to do. So those who could afford perfenadine, which was proven in idiopathic pulmonary fibrosis, I have been giving. So March, April, May, I have 3 months of data of long haulers on tapering steroids and NAC versus long haulers on tapering steroids, NAC, and perfenadine. I'm getting better results in the perfenadine group. I just wanted to share this. In 3 months, it's early days yet to say or to analyze the data. We are still too busy, but subjectively, and with the SATs and intermittent dips, definitely these events are less in the perfenadine group.
Thank you. Thank you, Dr. Kati. Malay Joshi has experience of using Feluda in the Kumbh Mela. Dr. Joshi, please. Could you unmute yourself, Dr. Joshi? I hope you can hear us. Well, we'll come back to you. Dr. Gaikwad has a question about occupational lung diseases and how that impacts. Dr. Gaikwad? Vikram Gaikwad, I think you're muted.
Sir, hello.
Yes.
2 to 3 questions. One question is that whether this finding of CT is permanent, irreversible, or what will be the finding after 2 months?
Very good question.
And second is question is regarding the occupational hazard. Some people exposing like flour meal, chula in rulers. There's still existing chula. And is there correlation for severity and mortality cases?
So there's one radiological question, one clinical question.
Dr. Joshi, do you want to take the radiology one?
The radiology one. And we have seen some amount of resolution of the interstitial thickening occurring over a period of time, but it's too early for us to say it as a general, rule that this occurs. We'll need to study more cases over a period of time and get back on this. But it takes time. It will take up to 6 to 8 weeks at least for resolution to occur. But some people, we are seeing more and more of lung destruction and the cysts developing, which definitely would not resolve. They may in fact rupture and you might get pneumothorax or pneumomediastinum late in the disease. So too early to say right now.
Thank you.
So I want to follow up on that one as well.
Mm-hmm.
Yeah, so I want to follow up on that one as well and say, like, we were following, we had our patients that went on to ECMO had significant amount of lung destruction. We were following them. And in those, we haven't seen recovery yet. So as Dr. Joshi was pointing out, if you start seeing honeycombing and fibrosis in the CAT scans, then those are not likely to recover. The other findings is still ongoing, whether some will recover or not, and how many of those percentage of patients recover. The other question that was there about occupational diseases, chulas and all. So chula smoke is or biomass fuel burning is the single highest sort of risk factor for developing COPD in the world. This is more than smoking in itself too. So that in itself puts your lung at risk for so it would be classified under like the chronic respiratory diseases that we have there. And so those people who are more likely to progress in their disease, if they end up getting COVID, they're more likely to progress towards worsening respiratory status. So if your question was, will this predict it? Then yeah, they're more likely to go towards worsening respiratory failure. They're more also likely to have worse symptoms as well too when it comes to COVID.
Thank you. Dr. Rege, did you want to comment on that?
No, so I agree with Dr. Aditya on that. So it is one of the risk factors for worsening. So.
Thank you. Dr. Joshi, you had experience, Malay Joshi. You're muted still.
Yeah, I'm not a pathologist, I'm a radiologist, but I'm associated with the lab that has done extensive testing with cellular platform during the villa. And what we have experienced is that the turnaround time is definitely lesser. The extraction and we have been able to provide results within 5 hours. But as far as the sensitivity and the specificity, there are no advantages or the platform. So really not an indicated test for not as somebody wanted.
Okay, thank you. Dr. Vijaya Gujarati has a question. Dr. Gujarati, please. Dr. Vijaya Gujarati.
Hello, good morning, sir.
Yes, hi.
If a patient is diabetic, 65 years old, and his CT score is 20 on day 8 or 9, what are the chances of recovery? And if it's recovered, what is his lung condition?
Very important question it's a clinical question as well as a radiological question.
So our clinical experience of patients like this, so they do take a lot of time to recover. So we have found that a lot of them, even though they require some form of oxygen therapy. I think a lot of times they do require even HFNC and NIV. A lot of these patients don't go off HFNC very early. So we do repeat their swabs at the end of maybe 14 days from onset of symptoms. And we de-isolate them in order to get better chest physiotherapy and rehabilitation, like pulmonary rehabilitation, and we found that very slowly they do get, they do also come off HFNC and NIV, and some of them get discharged on home oxygen. It is a long process, especially because of diabetes and severe COVID. It is a long process. It's a long, they need to be patient. We need to be patient, and they really need to be have tight glycemic control, and try and prevent as much as possible any sort of nosocomial infection. Try and get them out from the COVID unit or and the non-COVID unit, basically out of the hospital as soon as possible, and start the rehabilitation process sooner.
He's already on the ventilator, madam.
Ventilator above 65, it's tough. It's tough. Whatever we are seeing, till we can, if we can avoid the ventilator as much as possible, it is, it's better. But on ventilator above, at the age of 65, it's tough. I'm not saying that we're not seeing recoveries, but we need to prone these patients and avoid secondary infections. It is tough. It's going to be an uphill climb, that's for sure.
So talk about proning. That's a very important thing, right?
I think Dr. Aditya would be able to talk about that better than me.
Sure. Sorry, I missed the first part of the question.
There's a 65-year-old with a CT score of 20 who's on a ventilator and was diabetic.
So I will say whether they recover so as Dr. Rege pointed out, that the mortality starts rising as your age starts rising on the ventilator. Age greater than 65 the odds ratio is like 20 times more of mortality as compared to people in their 30s when it comes to mortality on the ventilator. It is not to say that people do not recover. We've had lots and lots of patients who have actually recovered on it. The question that really actually comes across is like, how soon in their disease process were they intubated? Meaning if they had progressed pretty rapidly and were intubated early, they're more likely to recover. If they have a slow progression and then they have gotten ventilated and intubated, they're less likely to recover. One of the things that came about early from Italy was the fact that proning as a way of ventilation was made popular because of ARDS, and in those patients, because of lung stresses and how the ventilation patterns were there, proning was actually helpful in making patients less hypoxic. In COVID, we have used a lot of proning, from self-proning, patient self-proning to proning patients with ventilators and proning patients with ECMO attached to them too. And this actually does tend to improve their oxygenation quite a bit. It's actually a fairly remarkable jump in their oxygenation status when you actually prone these patients, meaning what you do is most conventional patients are lying down on their back when they're being ventilated on the ventilator. We flip them over and put them on their stomachs and then and breathe for them. And this has been shown like it's actually far more effective to get their oxygen levels up. It's not as simple as doing oxygen. It's about using less oxygen to get it up. So it sort of improves their chances of survival at that point.
And that applies to ambulatory patients as well?
So yes, so it applies to ambulatory patients as well, in the sense like if you're hypoxic, one of the first things that we suggest is the easiest way to do is to prone yourself. Self-proning was one of the major reasons why we were actually able to keep a lot of patients outside the ICU in United States, and at least in our system of hospitals. We had a way of making patients do self-proning on the floors and at home in order to try and keep them away from higher amounts of oxygen needed, which would make them come to the ICU.
Thank you. And Dr. Nitin and Dr. Priscilla have been having an interesting conversation on the side about reducing radiation risk. How common and how easily applicable is it? I mean, if you're sending a patient to your friendly neighborhood imaging facility, can they do that?
Yeah, we can do it. We've done it. We called in the application specialist and we got him to set up an algorithm for COVID patients where we've reduced the slice, we've increased the slice thickness, we've increased the interslice gap, because we don't need to measure, we don't need to image at every few millimeters. We can image at every 10 millimeters or 15 millimeters, the findings are not really going to be very different. And we've also reduced the kV, that is a kilo voltage, and the milliampere seconds. So the radiation dose is reduced significantly. The newer machines, of course, have even further reduction in the doses because of better detectors and technology.
Thank you. Dr. Chitralekha is worried that some of the people with lower lobe disease, Dr. Chitralekha? She's worried about them being, yeah, go ahead.
No, I'm just sharing my experiences on chat. Proning doesn't work across the board. Every patient whose SATs are dropping, you just keep putting them into prone position. They struggle, they need more oxygen at the tissue level. Only those who I think accept it comfortably should be prone. People with, say, CTS of 16, 17 and above, and you've got evidence of lower lobe disease, which is primarily the posterior lobe, which lies posteriorly. Forcible proning against the patient's comfort, I find distresses them, and time to going on to BiPAP is much faster. So I feel
it's a very important question.
a lot more.
It's a very important question. It's very
So that's a
labor
fair
intensive,
point.
isn't it?
Recommended
Aditya?
across the board.
So that's a fair point. So forcible anything does not work. I mean, if you're forcing a patient to do something, it's not helpful in any situation. To answer your question about whether it's only in the lower lobes that happens, that's not exactly true. So it's more about one of the many ways that proning helps is also better VQ matching. So for example, if you're saying and I'm just as random, and I do not know how to answer this in terms of your CT scores. But if you have a patient who has more sort of upper lobe findings, then yeah, sometimes depending on where it is, a lateral position might actually be helpful. And if you have more certain other findings, it actually helps a lot more in VQ matching. That's one of the ways that is there. One of the other theories behind proning is that it reduces the stress, the shear stress that is available on the alveoli as well, which is what we used to see a lot about in ARDS patients. So in our intubated patients, we'll certainly go ahead and prone. There are caveats to our proning too, even in intubated, sedated, paralyzed patients. Is if I look at a CAT scan and just say like, look, he has unilateral disease, it's only one lung which is affected, which we do see sometimes, then that is somebody I would not prone, because I would make their VQ mismatch so bad that they would actually become hypoxic, like you're pointing out. So the
how
simple
much
suggestion.
manpower is required for keeping people?
My point is, if we give the message that prone everybody to the junior residents and the senior residents, I find it's not helpful. We must
a fair
being to the extent of comfort. Otherwise,
that is
see what happens is consultants are few, the working force is large, and this dictum based or a or what do you call it, the bundle, they are given a bundle, okay, give everybody this and do this to everybody. It doesn't work with universally. So comfort is a rider to proning.
So do you have a team that is doing the proning? Is it very labor intensive? The ICU?
So both of those things are actually true.
With obese people.
On an average, it takes about to safely prone a patient, because again, these are, when you intubate them, these are also hypoxic patients who have high risk airways. So you have to have one person controlling the head with the AT tube and about 4 others moving, and if there are lines and all attached. So it takes about anywhere from 4 to 6 people to safely prone a patient. That is there. So it can get labor intensive.
Yes, it is 6 people.
Yeah. And Dr. Kathy's point is absolutely well made. It's like, as a dictum, it's not useful. What is actually useful is to try it on a patient. If it works, great, you can do more. If it does not work, stop it. Don't force it onto people.
And Dr. Nitin is talking about proning and CARP. Dr. Nitin?
Dr. Krishnan, there's a question from Dr. Nitin that we need to address.
Yes, go ahead, please.
When it comes to diabetic COVID patients on steroids, he's mentioned that the duration of steroids should be limited to maximum of 10 days and no tapering required. Okay. all diabetics should be put on insulin for tight glycemic control, absolutely. But the point on antifungal prophylaxis to be given in all diabetic COVID patients on steroids, I don't agree with that thought process. We have a steroids and mucormycosis talk on this coming Wednesday, where an eminent speaker like Dr. Rajiv Soman will be addressing these issues. But I'd really like to add that even when we talk about giving mold prophylaxis in stem cell transplant patients, we give it in patients where you have an incidence of more than 10% of invasive molds. Only in those patients you give a prophylaxis against molds. In steroids, the number needed in COVID-19 patients on steroids, the number that you would need to prophylax would be so high. And I don't think that there is any there is no data behind giving antifungal prophylaxis at this point, because the incidence of mucormycosis in patients with COVID-19 is not above 10%, as far as whatever I have seen, whatever cases have been published. There is a fungal infection study forum of India, which has around 16 centers which have contributed cases. And even in those 16 centers all across India, they have found that the incidence of mucormycosis is not exceeding 10%. So we still rely on using steroids judiciously, controlling sugars, and early diagnosis, early suspicion, and debriding earlier and starting treatment earlier as compared to antifungal prophylaxis. I don't think we should be talking about prophylaxis, so at this juncture.
Do you want to take Dr. Dhamija's question about dosage of steroids and what do you use for methylprednisone?
So we use dexamethasone of 8 milligrams a day, which is what the guidelines state. If you have to use methylprednisolone, it has to be the equivalent of 8 milligrams of dexamethasone. So that would be around 32 or 34 milligrams per day. That would be the kind of steroids that we are using at our center, because that is what the protocol says.
So as a stem cell transplanter, we give steroids for longer duration. So if you don't start steroid antifungal early on, do you stop the steroids after 10 days regardless?
No, so if a patient is requiring oxygen for a longer duration, if a patient is still hypoxic, we don't stop the steroids at 10 days. We aim to stop steroids as soon as possible. So if a patient is not on oxygen, we don't ask them to go home on steroids, or we taper it really fast and stop. There are also certain questions on data for giving broad spectrum antibiotics for all patients of COVID. There is absolutely no role of giving broad spectrum antimicrobials to prevent a secondary bacterial infection in COVID. We need to diagnose it earlier. So all patients on steroids they receive some form of antibiotics. We have seen that. We have a very strong stewardship program in our hospital. So we have a lot of we have our stewardship pharmacists who go everywhere, and they keep poking all our physicians and intensivists for stopping the antibiotics, and only start an antibiotic if we suspect a secondary bacterial infection after sending cultures, and then we start it. Because more often than not, we find that a person who has been started on some antibiotic has a secondary infection which is resistant to the antibiotic that the patient has already been on, without indication. So
thank you.
So I think I'm going to echo those findings as well too, because I think the idea of antibiotic stewardship is actually really key, because a lot of patients coming in with respiratory failure get started on it, and we rapidly de-escalate and get rid of antibiotics while we are very vigilantly watching for a secondary infection. And if there is data to prove that there is secondary infection, then the antibiotics, or there's like high clinical suspicion, then they get started up again. We don't actually, for anyone with COVID, within 12-24 hours, if the ER has started them on antibiotics, we have gotten rid of those antibiotics pretty fast to sort of from our antibiotic stewardship.
Thank you. And Dr. Kati is bringing up about candidemia. Mucor has got all the publicity. What about candidemia?
So I think this is one of those topics again, which will get covered in the other talk as well. But the reality of it is, yes, candidemia is a little more seen than mucor, while it has gotten more of the press. But again, it sort of comes back to your duration of steroids and all other illness, all other comorbid conditions that you have that are related to the candidemia. As such, COVID is not the part of it. It's just everything else that is associated with COVID that is coming, the intensity of steroids, the duration of steroids, any other secondary infection, immunocompromised state, nutritional status, everything else that comes, which the lines being in place, which brings you at risk for fungal infections.
Sure. Is there any situation in which you've given antifungal prophylaxis?
As without any sort of without any findings of any pneumonia or mucor? The answer is no. We have not done any in any of our system hospitals. We have not given any prophylaxis. Even for diabetics, we have done strict glycemic controls and gone away with that. We haven't seen any other rise in infection from that.
Okay. Well, Dr. Saurirajan Rajagopal has been asking about a more detailed discussion. Perhaps this is the time to call in Sudaranjan to talk about our next session. Sudaranjan, please.
Yes, sir. I think I'll try to attend the other seminar.
Okay. Thank you, Dr. Rajagopal. But Sudaranjan is going to give you some details about it. Sudaranjan?
No, recently there were some articles in the newspaper about this complication of fungal infections among those people who are administered with steroids. So I would like to know more about it.
Sure. Sure. I think we've had addressed a few questions, but hopefully on Wednesday morning we'll have an opportunity.
Yes, there was some information. I gathered some information.
Yeah. Thank you.
Thank you. Thank you.
Okay, just to remind all, our next session will be on the Wednesday, that is 19 May, 8 a.m. Indian Standard Time and 10:30 US Standard Time on 18th. We'll share the invite with you, and I have just posted a feedback link in the chat box. Please give your valuable feedback so that we can improve our next sessions. We have recorded this session and it will be on the YouTube soon. And we'll be also sharing a Google form link where you can put up your questions for the upcoming session. Thank you very much for joining us, and good night and have a good day. Bye.
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Thank you.